Hello guys, in this video let's see a very important chapter which is metabolic response to injury. In this chapter we will basically learn how the body responds to a injury, which may be a trauma or a surgery. This video will be useful for all the surgical residents as well as the MBBS students across the years, mainly for the third years and the fourth years. This video basically concentrates on going behind the scenes on what is the pathophysiological basis for the changes which we usually encounter in a surgical patient. So before before knowing them, let's see what is homeostasis. As we have known in physiology, it is the maintenance of stable internal environment for optimum cellular functioning. As I have told you earlier, injury can be a surgery, trauma, or anything which disrupts this internal stable environment, which ultimately leads to organ dysfunction. So basically I want to tell you that my aim in this video is to give you the concept and the gist of how our body reacts whenever there's trauma or injury. So the metabolic response in our body happens in two phases. One is the catabolic phase, other one is the anabolic phase. Catabolic phase is the breakdown phase. Anabolic is the one in which our body restores itself. Catabolic phase is the immediate response of the body to an injury. The various the changes which are seen in catabolic phase are mainly hypovolemia, decreased metabolic rate, reduced cardiac output, hypothermia, and lactic acidosis. In coming slides, we will see how these changes are brought about by the body and why do we need them. The main goal of this hypovolemia, decreasing the metabolic rate, reducing the cardiac output, hypothermia, lactic acidosis, is to maximize our survival. These things, by reducing the circulating volume, by reducing the body temperature, what we do is we conserve the energy stores and the circulating volume so that they can be used up once our body tides over this stressful phase. Even though our body mounts these responses to conserve energy and protect us, but whenever these responses overshoot, they lead to a syndrome known as systemic inflammatory response syndrome, which we will learn in detail in coming time. The various other effects which involve the catabolic phase are muscle breakdown, weight loss, and hyperglycemia. Ultimately, all these things, if they are not controlled, will lead to sepsis. After the catabolic phase, there is anabolic phase. Once we tide over the stressful phase of catabolic initial injury period, then we have to restore our body stores. So in anabolic phase, we focus on recovery and tissue healing. It can usually last for weeks or can be done within few days. Keeping in mind these two phases, the catabolic phase, anabolic phase, our presentation will usually revolve around understanding why these changes occur in the catabolic and anabolic phase and what effect does these changes have on our body in long term. So a brief point about management. The surgical critical care which we give today to the patients basically revolve around these changes. That's why it is important to know these changes so that we can manage them accordingly. In a modern surgical critical care, it basically focuses on resuscitation and organ support, and this is alongside the metabolic effects of injury. And these metabolic effects are nothing but the catabolic and the anabolic phase effects which we see. The ultimate aim of a surgical critical care is to restore the patient to the state to normalcy. He should be returned to a state where he was before surgery. That is the aim of the care which we give to the patient. Few of the systemic side effects of the injury which we can see in a patient are loss of muscle mass, sepsis, and multiple organ dysfunction. We can see here that majority of the hospital deaths in developed countries which occur after the injury are due to complex physiological processes, not just direct organ damage or blood loss. This underlies the major importance of understanding the pathophysio behind these effects. The inflammatory response which occurs after the trauma or injury or a surgery can also cause immune suppression, which can ultimately increase the risk of infection and sepsis. And sepsis will push the patient towards multiple organ dysfunction syndrome. And it's noteworthy here to mention that once a patient develops MODS, the mortality rate is around 25% even in the best of the setups. So what we have seen is nowadays elective surgeries are minimizing the homeostatic response by reducing the insult. How can we reduce the insult? By minimal access surgery, by having enhanced recovery after surgery, giving the patient a stress-free perioperative care. The magnitude of injury and response. Here we can see that the severity of injury usually correlates with the intensity of metabolic response. It shows that more is the severity of injury, the metabolic response also will be more in intensity. This applies to across all the status of metabolic response, whether it is physiological, metabolical, immunological, or others equally. Following a major surgery, whenever a patient undergoes a major resection or say simple surgery like cholecystectomy, post-operatively please see the WBC count, it will be raised. And it doesn't imply that there is infection. It's just a response of the body to the surgery. Surgery is also a trauma. Surgery is also a self-inflicted injury to the patient. So post-op period, there will be raised WBCs which will settle down with time. There can also be tachycardia, tachypnea, but this will be transient and within reasonable amount. But whenever these inflammatory changes become uncontrolled, then this inflammatory response will turn into a storm, which we know as systemic inflammatory response syndrome. Ultimately, the patient will land up in hypermetabolism, which leads to shock and possible MODS. Let's see the pathophysio behind the inflammatory response which is generated by our body. It is very interesting here to see that whenever there's a tissue injury, our body releases damage associated molecular proteins. These are known as DAMPs or alarmins. This damage associated molecular proteins are sensed by pattern recognition receptors, which everybody would have studied in pathology. These DAMPs are sensed by pattern recognition receptors like toll-like receptors or knot-like receptors. What this do is, once this tissue injury, it is the very mechanism of the body to sense that somewhere in the body there has been an injury, they have to mount an inflammatory response. So this is mediated by the DAMPs. This DAMPs, when sensed by pattern recognition receptors, body comes to know that yes, there has been an injury, there has been a trauma, we have to respond. How do they respond? They respond by creating inflammasomes. Inflammasomes, which in turn activate caspases, and caspases we know they bring about cell death. They activate enzymes, they bring about cell injury. And they also release key inflammatory cytokines. We all know interleukin 1, 6, tumor necrosis factor alpha. They are all important mediators of inflammation. These cytokines, tumor necrosis factor, all these are, we can say, a mode of communication between cells to say that yes, there is an injury, there is an inflammation, there is a trauma going on in the body, we have to respond. So they communicate with each other through these molecules. That's how beautiful the pathophysio is behind, which is behind these changes which we see in a patient. So what we can say is, once DAMPs are released following tissue injury, DAMPs are sensed by pattern recognition receptors, which in turn activate and release cytokines. And cytokines, we know they bring about the changes like endothelium gets activated, there's chemotaxis, there's recruitment of the neutrophils, macrophages to the site of injury, which in turn releases free radicals which cause tissue damage. And when this response becomes uncontrolled, which is we known as systemic inflammatory response syndrome, in which we know TLC becomes more than 12,000 or less than 4,000, heart rate is increased, all those changes are seen. Ultimately, what will happen? Cell death, tissue damage, and immunosuppression. You will see forward how immunosuppression occurs in inflammation. It's basically due to high levels of cortisol, neurochemical pathway, which leads to immune suppression. And also, as I have told earlier, there can be endothelial activation, which leads to leaky capillaries and coagulopathy. And coagulopathy will ultimately lead to decreased blood supply to the organ, which leads to tissue damage and local ischemia for the organ failure. So ultimately what happens in systemic inflammatory response syndrome is multiple organ dysfunction, acute kidney injury, lung injury, coagulopathy, multiple organ dysfunction, and organ failure. The neuroendocrine response to injury. In this slide, we will basically learn what are the reasons behind the rise in the hormones which we see, like cortisol, growth hormone, glucagon, the so-called counter-regulatory hormones which increase during the stress. What happens is, The nociceptive neurons in the spinal cord, thalamus, hypothalamus, pituitary are activated by inflammation. Once these neurons are activated, they release CRF, corticotropin releasing factor, from the hypothalamus. What CRF does is it acts on the pituitary to release ACTH. Then ACTH goes to adrenal glands, it releases cortisol. And cortisol, we know it causes hyperglycemia. It also causes immune suppression. And also, hypothalamus, once activated by the tissue injury, not only its neurons release corticotropin releasing factor, it also triggers the sympathetic neuron system, releasing adrenaline and glucagon. So what this tells is there's a neurochemical basis for the hormonal increase in our body which is seen during stress response. The hypothalamic neurons are activated, which release the CRF, which acts on the pituitary to release ACTH. ACTH acts on adrenals, which releases cortisol. The hypothalamus also activates the sympathetic nervous system. Once sympathetic nervous system is activated, adrenaline is released, glucagon is released. So ultimately cortisol, adrenaline, glucagon all increases, which brings about the various changes which we are going to see in further slides. Once these hormones increases, what they do is they cause the breakdown of carbohydrates, fats, proteins to provide energy and support the repair. What we have seen is how they have come to know that these changes brought about by glucagon corticoids is they have administered this hormonal cocktail and they have observed the same metabolic response to injury which we see during a stressful phase in human beings. The additional effects which are seen due to these hormones is insulin release and alterations in the insulin release and increased insulin resistance. This growth hormone increase also causes insulin antagonizing effect, which is insulin resistance, and lipolytic effect and pro-inflammatory properties. So what we have to get from this fact is tissue injury leads to activation of hypothalamus. Hypothalamus releases CRF, CRF releases ACTH, ACTH causes cortisol. Hypothalamus also activates sympathetic nervous system, it causes release of the adrenaline, glucagon. These hormones, then what do? They cause breakdown of the carbohydrates, fats and proteins to provide energy. We have to understand the fact that everything which happens in the body has a reason. Our body is the most intelligent creation of God and everything which it does has a reason. Our aim in this video is to understand that flow. Why the injury response happens, how it happens, what does it do to our body. Whenever there's injury, let's summarize what we have learned till now. Whenever there's injury, what happens? Whenever there's injury, there is activation of release of certain damage-associated molecular proteins which are sensed by pattern recognition receptors. This in turn releases cytokines. Cytokines acts on the site of tissue injury, exaggerates inflammation, causes cell death and tissue damage. This tissue injury, when sensed by hypothalamus, causes release of various hormones. These hormones in turn causes breakdown of carbohydrates, fats, proteins to provide energy and support repair. Now, this slide here summarizes what we have seen before. The innate and the adaptive immune system interaction is it is activated by the DAMs. Macrophages interact with the T cells and the B cells. They co-generate the metabolic response to injury. The pro-inflammatory cytokines which I have seen previously, interleukin 1, 6, 8, TNF alpha, causes pyrexia. So the fever which we see in acute stressful phase, that fever may not always be due to infection. It can be due to inflammation, hypothalamic stress response. Okay. Similarly, proteolysis in skeletal muscles and acute phase production all is mediated by the cytokines and further by hormones. The cell death and tissue repair. If you see in detail, the cell death and tissue repair is mediated by complements and kind pathway. This pathophysio not that important. What we have to see here is cortisol is immunosuppressive, which explains the fact that inflammation leads to immunosuppression. That immunosuppression leads to higher risk of infection. Infection proceeds to sepsis. Sepsis proceeds to MODS. So we have to get that sequence. The basic aim of this chapter is to understand the reasons behind the various manifestations during a surgical stress response. Cortisol is immunosuppressive at high levels. It synergizes with interleukin 6 to promote hepatic acute phase response. ACTH released, we already know it is stimulated by hypothalamus. It is also enhanced by pro-inflammatory cytokines and noradrenergic system. Cortisol may also create a weak feedback loop to limit inflammation. But what we have to get here is everything, whatever response happens, everything is culminating at one point to promote tissue destruction to promote further tissue damage if it is uncontrolled. We know that glucagon is released. We know there's insulin resistance. Whenever there's insulin resistance, there's increase in glucose levels. And glucagon also promotes hyperglycemia. So in a stressful phase, in a surgical patient, we often see that it is difficult to control their blood sugar levels. And what is the reason? This is the reason. There's insulin resistance. And why there's insulin resistance? Because of the pro-inflammatory cytokines, and there is increased glucagon, which creates the increased hyperglycemia. What does that hyperglycemia do? It promotes oxygen free radical formation, which further promotes inflammation. See, here we can see a positive feedback loop. Inflammation, tissue injury promotes inflammation. Inflammation leads to release of cortisol, glucagon, insulin resistance, which causes hyperglycemia. Hyperglycemia in turn generates oxygen free radicals, supports the inflammation. Such is the feedback loops which keep on going if we do not limit the damage and get control of them. So let's summarize what we have known. The metabolic changes after surgery and trauma can be catabolic phase, anabolic phase. Catabolic phase is first 48 hours post-injury. It is characterized by hypovolemia, reduced metabolic rate, hypothermia, reducing the body temperature, lactic acidosis. All these changes are brought about by the body to limit the circulating volume and reduce the energy expenditure, so we can store them for restoring the body's internal environment once we tide over the acute stressful phase. These changes which you see in catabolic phase are brought about by various regulating hormones like cortisol, catecholamines, aldosterone, glucagon, and inflammatory cytokines interleukin 1, 6, TNF alpha. And we know how these catecholamines, cortisol, aldosterone, glucagon are produced by activation of the hypothalamic hormones CRF, ACTH, cortisol, activation of sympathetic nervous system, release of adrenaline and glucagon. And we know how these inflammatory cytokines are produced because the tissue injury releases damage-associated molecular proteins, DAMPs, sensed by pattern recognition receptors, which in turn release cytokines which promote tissue damage. Another important fact is there is significant fat and protein mobilization which leads to weight loss. These are also due to hormonal effects. And when there is, we have seen earlier that there's also muscle breakdown in the catabolic phase, which is brought about by that growth hormone, which is brought about by that adrenaline. The protein breakdown in skeletal muscles is brought about by the pro-inflammatory cytokines and various hormones. Okay, this in turn leads to increased urinary nitrogen excretion, which is also a pointer to say that there's increased muscle breakdown whenever there's increased urinary nitrogen excretion. From this phase, post resuscitation, the body, if the metabolic phase isn't controlled, it's transformed into hypermetabolic flow phase. What happens is the body enters into a stage where there's mobilization of energy stores for recovery and tissue repair. But if there is uncontrolled inflammatory response, it leads to tissue edema from vasodilatation, capillary leakage. And we know why capillary leakage happens, because of endothelial damage. Who does the endothelial damage? The inflammatory cytokines. From where did the inflammatory cytokines come? From the activation of the pattern recognition receptors from DAMPs. From where did the DAMPs come? The DAMPs, tissue-associated molecular proteins, came from tissue damage. Okay. There's also increased metabolic rate, increased cardiac output, leukocytosis, which you have already seen, and gluconeogenesis. It occurs due to increased glucose breakdown. This slide shows that the energy expenditure in a trauma patient is about 15 to 25% higher than the predicted healthy resting values. This shows the importance of nutrition in a surgical patient who is already expending more energy than his resting values. The pro-inflammatory cytokines, increased sympathetic activity, abnormalities in wound circulation all contribute to the elevated energy expenditure. Increase in cardiac output, energy utilization, tissues like muscle and liver all contribute to hypermetabolism. This basically underscores the fact that all the things which I have seen, increase in cytokine, increase in sympathetic activity, all lead to increased energy expenditure, thereby making us aware that nutrition plays a very important role in recovery of the patient. The only clinically relevant thing which we have to take from this slide is good nutritional status helps patient to recover faster after a surgery. Now we will see important changes which are brought about by a trauma or a surgery in a patient and how to manage them. First thing is volume loss and fluid retention following an injury. What happens is, whenever there's a volume loss, we know that the volume loss is sensed in the carotid artery and the aortic arch by the pressure sensing receptors, which are BAT receptors. Once the volume loss is sensed by these baroreceptors. These are activated, and what do? They send the response to CNS. Similarly, there's a volume receptors in left atrium. These baroreceptors and volume receptors send the response to CNS. Let's see, we have less circulating volume in the body. In response to that, what CNS does is it releases ADH. ADH causes fluid retention. As the name suggests, it is an antidiuretic hormone. It works against the diuresis. It reduces the urine output. It conserves the fluid which is present within the body. And also, when the circulating volume reduces, we know there are receptors within the proximal tubules which sense the decreased circulating volume within the kidney and activate renin-angiotensin system. The ultimate byproduct of renin-angiotensin system is aldosterone. Angiotensin activated forms angiotensin 1, renin converts angiotensin origin into angiotensin 1, angiotensin 1 angiotensin 2 by angiotensin convertase enzyme. Angiotensin 2 acts on the adrenals to release aldosterone. The aldosterone, what it does is it promotes sodium reabsorption from the tubules of the kidney, which ultimately conserves the water. So the aftermath of these effects is ultimately oliguria, low urine output after surgery, water and sodium retention in the extracellular space. So why we are studying this slide is already during a injury, during a surgery, the body knows to conserve fluid. It is limiting the body stores, it is conserving fluid. So whenever there's decrease in output, we should not pump fluids within a patient thinking that there's low urine output. No, we have to understand this basic fact that body is going through a stress after a surgery. It will try to conserve the body fluids, so it's a normal response. We have to allow it to tide over by itself. What we have to do is we have to limit the intraoperative use of crystalloids, which can prevent the net weight gain and reduce the postoperative complications. Otherwise, what will happen is if we keep on pumping the fluids, it will cause pulmonary edema. Patient will have hypoxia. He will land up in metabolic acidosis, ultimately cardiac failure and death. Another important factor is hypothermia. Hypothermia, when it happens during injury, it leads to increased production of adrenal steroids, and we already know what steroids are capable of doing during an inflammatory stage. Even mild hypothermia can increase the risk of cardiac arrhythmias and accelerated breakdown of the body tissues. Why there's so much fuss about hypothermia and maintaining normal body temperature during surgery is we have seen that maintaining normothermia during surgery can reduce the wound infection, it will reduce the surgical site infection rate, it will reduce the cardiac complication, and also it will reduce the requirement of bleeding and blood transfusion. The most effective intervention which they have found is upper body forced air heating cover, which helps maintain the body temperature during the surgery. One thing which you have to remember from this slide is normothermia reduces the wound infections, reduces the cardiac complications. How to bring about that? Upper body forced air heating cover. Okay. Another thing is, apart from volume loss, hypothermia, other important factor which you have to take care is systemic inflammation, tissue under perfusion. We know excessive endothelial activation, what it does is it promotes microcoagulation. Within the microcirculation, there is formation of clots, and when there's formation of clots, there's reduced blood supply to the tissue, which leads to cellular hypoxia, ultimately increasing the risk of organ failure. There's also a very important role of blood sugar control. We have already seen when the body is in stress, release of hormones, cortisol, glucagon, insulin resistance, hyperglycemia, which in turn, hyperglycemia itself perpetuates inflammation by oxygen-free radicals. So, when you go to ICUs, surgical care ICUs, you see anesthetists running insulin infusion. Why? Because to regulate the blood sugar levels. Insulin infusion during critical illness helps regulates blood sugar. This is a very important thing. And it not only it's regulate blood sugar levels, further helping in limiting inflammation, it also protects the endothelium by potentially inhibiting excessive inducible nitric oxide synthase, which induces increased nitric oxide release, further limiting the inflammation. So today we have learned an important thing. Insulin infusion not only helps regulate blood sugar, but also it helps regulate inflammation. Another thing is, now we will get to know why there's muscle breakdown, why there's lipolytic effect of the growth hormone, why the hormones have to come into play to break down the fat, glucose molecules, etc. because anything and everything in our body requires energy. Energy comes from glucose, and moreover, the most important organ which is functioning in our body is brain. The brain solely depends upon glucose. So, for the first 24 hours of the injury, glucose is produced by glycogen stores. But glycogen stores are not endless. After 24 hours, body falls onto gluconeogenesis. As the name suggests, we are synthesizing new glucose from products apart from carbohydrates like amino acids, glycerol, lactate. From where do the amino acids come? From muscle breakdown. So someone has to break the muscle. Who will break the muscles? The hormones will do. Where will the hormones come from? From the inflammatory response. Everything is linked. Only when we will study and approach a topic sequentially, we can understand the reason behind that and its clinical relevance. Now everything is falling in place, right? We need glucose. Glucose is produced by mobilizing the glycogen stores within first 24 hours. After that, it is synthesized from amino acids. Amino acids come from muscle breakdown. That's why we have seen metabolic response to injury involves muscle breakdown. Why it involves muscle breakdown? To produce amino acids. Why amino acids are to be obtained from breaking muscles? To synthesize glucose. Why do we need glucose? To provide energy to the brain, which mediates entire body. Also, there is fat mobilization. Fat is mobilized from adipose tissue. To do something, we need something. To mobilize fat, again we need a hormone. Here comes the growth hormone, which is lipolytic effect. Here comes the cortisol, which has lipolytic effect. Fat from the adipose tissue provides energy to other tissues. How do we mobilize fat? From the hormones. Fat, once it is mobilized, it ultimately leads to lean tissue loss. And when fats are utilized for energy, ketones are produced. Lean tissue loss is reduced as the liver converts free fatty acids to ketone bodies for cerebral energy. So, all in all, this explains what we have learned, have made sense in this slide. So, to maintain the glucose levels of the body, we have to inject dextrose. This line shows 2 liters of 4% dextrose provides around 80 grams of glucose per day. And the most important thing, nutritional support in surgery. We have to avoid the new thing is we have to avoid unnecessary fasting. We have to provide early enteral parenteral nutrition to the patient. Best is oral nutrition followed by enteral parenteral as the patient tolerates. Even the guidelines have said that we can allow clear fluid intake up to 2 hours before the surgery. They have even said that the carbohydrate drinks can reduce perioperative anxiety. As we have known, we have to make the perioperative period stress-free to reduce the response of the body to the stress during the surgery. So the carbohydrate drinks reduce the perioperative anxiety, thirst, postoperative and postoperative insulin resistance. So small things can bring about such changes which ultimately improves the patient care. Finally, whenever after surgery we encourage the patient to mobilize, we say him to mobilize, to get up from the bed, to move if possible. Why? Because inactivity is a major cause of muscle wasting and we do not need muscle wasting. We have to restore the body stores as early as we can. So what do? We have to avoid unnecessary bed rest. We have to encourage early active mobilization. And the rehabilitation programs include improving muscle strength, function before surgery so that the patient recovers faster. As we know, today the norm is for the better recovery of the patient following surgery, we have to take care about his pain. We have to give him a good analgesia. We have to encourage him to do mobilization. We have to encourage the attenders of the patient to do good chest physiotherapy to reduce pulmonary complications. These 3 things will enhance the recovery and thereby giving him a good outcome following a surgery. So in this way, we end this presentation here. In this chapter, what we have seen is how the body mounts a response to a surgery, to a trauma, what factors brings about those changes in the body, what are the molecules, what are the hormones which are involved in bringing about those changes, what are the changes and what effect do they have. If I have to say in few lines about the important gist about this topic is, whenever there's trauma, whenever there's injury, it is sensed by our body in the form of tissue damage associated molecular proteins, which in turn promotes release of cytokines. Cytokines promote tissue damage. Parallelly, there's activation of the neurons in the hypothalamus, which release the hormones like cortisol, glucagon, adrenaline, and activation of sympathetic nervous system. And these hormones, they cause hyperglycemia, they cause muscle breakdown. This hyperglycemia in turn perpetuates inflammation. This muscle breakdown leads to loss of proteins, amino acids, and why are these muscle being broken down to give amino acids for glucose production, and how are these detected? This muscle protein breakdown is detected by increased urinary nitrogen excretion. And what and our, since we have understood these things, our aim is to control these things so that these responses do not progress to SIRS, systemic inflammatory response syndrome, followed by sepsis and death. How can we minimize the response? Modern day surgery involves minimal access surgery, robotic surgery, enhanced recovery after surgery, so that we can limit the trauma, limit this inflammatory phase, and patient should recover faster. I hope who all have listened to this video got the gist of the topic. You can use this PPT for writing the short notes during this exam to understand, to get a basic knowledge about this first chapter of Billion Love, metabolic response to injury. If you like this video, please tell in the comments. I will continue the series and I will make a presentation, an interactive session on every chapter of Billion Love, and also it will be useful for those who are preparing for entrance examination. I can also make a video which are relevant to the entrance points of view regarding surgery. Okay, thank you so much for listening. All the best.